So we will be talking about forward-looking statements. Those forward-looking statements come with risk and uncertainty based upon the expectations we have today and can change. So I would just encourage you guys to all read the disclaimers associated with the forward-looking statements. P3 Health Partners, at a glance, we're a physician-led, value-based care organization. Really what we're doing at the end of the day is operate under both fully and partially delegated risk arrangements with payer partners. We operate in 4 Western states that you can see highlighted there in blue. We have about 116,000 lives under our management. We have 2,800 physicians in our network, and we have 18 payer partner contracts. The 3 defining kind of characteristics of P3 at the end of the day are we are capital efficient. Unlike kind of our clinic heavy partners and peers, we can scale with limited capital requirements on a go forward basis. We're deeply integrated. We bring data, technology, and care teams together around the PCP to drive better output. And that outcome-driven results are what we're trying to drive towards, which is our quadruple aim, which is driving superior clinical outcomes, higher patient satisfaction, lower cost of care, and then ultimately, we also want to provide prevent provider burnout. And if you know providers in a fee-for-service model, they are very much, it's a shop that comes in every 15 minutes, you get a new appointment. The value-based care model is trying to bring that and change that paradigm and really get providers back to practicing and influencing care on a holistic basis across a member population. This is where we're operating. Within, on the left side of this screen, you'll see we've got our 4 markets, Arizona, Nevada. We're in a singular county in California, and then Oregon. And the shaded colors within each one of the states represents the counties that we operate inside of those respective states. The thing that's really good about P3 and our opportunity set is our growth trajectory isn't necessarily about new geographies. It's about getting denser and deeper into the physician groups that we are already partnering with and getting more of their lives. The more lives we can get with them, the more mind share that we have of them, the better they can execute on the operating or the care enablement model that drives the quadruple aim that we were discussing. And we think inside of the groups or the markets that we operate in, there are about 2 million lives that we aren't contracted for. So what we're trying to demonstrate is there's a significant amount of growth that we can do without having to expand geographies or expand payer partners. Our mission is to be, the best healthcare partner for our patients and our providers. And really, it's built upon kind of these 5 core tenets here. We have a large, rapidly growing kind of addressable market. There's more seniors that are entering the Medicare Advantage space, which means that there's more opportunity for us to continue to drive value with that group of seniors, where that spend is increasing each and every year. We believe we have a pathway to profitability. P3 historically has not been a profitable company, but we believe there's a pathway to profitability. We'll talk about that a little bit more in some of the subsequent slides. Like I said, we have a fully delegated risk model, and really we're trying to bring tools and data and administrative support to our physician network that is trying to drive that outcome that we discussed. And then we have scale, and we can do that in a manner that doesn't cost us a ton of capital in order to expand the current data set that we currently have on our membership population. And then the last thing is, and we've got a slide at the very end, but we've got a really experienced leadership team. I would say 75% of the leadership team has turned over in the last 18 months, from CEO to me, the CFO, our CLO. Our COO is been with the organization for about 2 years. And then we've got some underlying market leadership positions that we've added to the organization that are really starting to round out that experience level that can drive ultimate outcomes across our results. So the market opportunity from a P3 perspective is pretty significant. Annual healthcare spend is trending towards, effectively $5 trillion. Inside of that, you've got $1 trillion that's related to just Medicare related spend, and inside of that, MA spend is at $500 billion. And we really think with that size of opportunity that we're trying to ultimately, the payers need a platform, and a platform like us to drive and control their cost structures. And that's what we're doing by taking on risk from them and providing better care, better quality of care. We've got MA rate recovery and kind of some tailwinds that have hit the marketplace. So up through 2024, traditional MA benchmark reimbursement was around 2.5%. This year in 2026, it's being increased to roughly 5.5%, kind of all things being said. And so we actually think there's some rate recovery that's going to drive that dynamic moving forward and increase profitability. And those that are succeeding in this space are actually have opportunity for strategic industry consolidation. All those things kind of set together, the size of the opportunity here that we're trying to manage, as well as the industry dynamics. We really feel like it's an opportunity for P3 to go and execute and drive the value that we're seeing collectively across our results and expectations for 2026. Excuse me. MA enrollment is at Medicare Advantage enrollment is about 54% of the total Medicare population. So it has increased from 35% in 2017 to the 54% you see today. We actually expect that in 2026 to relatively level off. But what you'll know is that seniors are continuing to age into Medicare because of the baby boomers at an increasing rate. So we don't have to have the penetration continue to increase, and we will see an increase in the actual enrollment numbers.
And is that growth because there's a lot more older people?
People are aging into Medicare, yes.
That's like a doubling.
Yeah. So we actually think that the penetration, the amount of people selecting MA will be about the same this year in 2026, but the sheer number of people will go up.
Really, that's a huge amount of growth.
Yeah, exactly. And when done right, Medicare Advantage really does work well. This graph on the right side is a depiction from a 2023 New York Times article, and effectively was trending annual Medicare spending per beneficiary from 1970 through 2010. And that's where you see that steep curve continuing to go up. Then in 2010, it really, the spending per beneficiary has kind of leveled off over the course of that time, where the expectation should have been that it should have continued to rise across that steep slope. And you'll see it's about a 30% reduction as compared to the projected trend line since 2012. And that is really associated with the Affordable Care Act.
These numbers are 2 years old. What do you think it is currently?
I would say that the actual spending has probably gone up a bit over the last 2 years. You've seen inflation and some utilization things increase. As this data was run, there was a big, out of COVID, there was about a pent-up demand where seniors weren't being seen for preventative issues. And so that fell out at the end of 23 and the end of 24. So I expect that to go up just a bit. But the baseline trend is that Medicare Advantage is doing what it's supposed to do in managing costs.
Quick question.
Yeah, absolutely.
What accounts for the gap between expectations and the actual way it just leveled off like that?
Yeah, in 2010, the Affordable Care Act was initiated, and that was really, Medicare Advantage has been around for a while, but that was really where a lot of people made larger plays in Medicare Advantage. So you had Optum Care buying up a lot of physician assets, things of that nature. And so you really saw, and as you see the coordination with the penetration of MA from the 34% up to the 52% or 54%, you're seeing a bigger portion of beneficiaries enrolling in Medicare Advantage, and that's thus driving the overall cost down,
Okay, great.
as opposed to just traditional Medicare fee-for-service as a product. So in today's kind of environment, there's a lot of challenges out there across physicians. When we deal with a physician group, they really lack the resources and expertise for the value-based care transition. They're really molded into a fee-for-service model, and so they lack the ability to kind of execute on that at scale. The payers ultimately need, demonstrratable ROI, and that's what they're leveraging us for. Health systems are primarily, operating at a loss from a Medicare Advantage perspective. And then really you've got fragmented kind of local markets that are disconnected with PCP groups and creating care coordination. P3's solution here ultimately is to deliver measurable cost savings while driving enhanced outcomes. And we do that both from enhancements with and relationships with our payer partners, as well as really driving back office tooling for our physician groups that we engage with. So we provide point of care tools, we provide care management models, where you have a physician group that might not be as sophisticated in how to deal with a specific chronic case or chronic condition or set of chronic conditions. We help provide that care management plan for those individual members based upon a risk stratification exercise. Collectively, all said and done, when we put this together, we're really creating that unified kind of protective care networks and coordinated touch points for that PCP group. This is what I was alluding to, I would say, is the fee-for-service model is effectively broken. It doesn't work. Depends on your perspective of who it doesn't work for, but just for the ecosystem as a whole, it's not working. The costs are high, utilization is high. Quite honestly, access to care is relatively low, and it creates patients trying to find their own avenues and mechanisms to try to navigate care. And then the thing on the right there is that physician burnout, which is actually pretty significant. Physicians got into medicine to help people. They did not get into medicine to be a output shop of widgets and gadgets. And that's what fee-for-service effectively is trying to do. And really holistic value-based care, you have time to sit down with a member for 45 minutes, understand their holistic care, their issues, and really navigate their care plan moving forward and create meaningful value to that member that is then rewarding back to the physician. And that's really where we think we can drive some increased value to the networks that we operate at. So, provider engagement, care management, and data analytics. That's the key to success from our perspective, is that if we can get that engagement across the providers that are in our network, we can then help them drive the right level of quality outcomes and align incentives to meet those outcomes. We have a team that provides the care management tool set in the background, and we have frontline care enablement individuals that actually partner with the individual practices that we are engaged with. They will go so far as to schedule appointments with the members that are under our care and make sure that member that comes in, that their documentation, their chronic issues are in a package that enables that physician to have the right level of conversation in order that we can document the burden of illness and then create the right care plans out of it. And ultimately what we're trying to do for these physician groups is we're trying to stratify the risk profile. And we're trying to say, hey, your 20% of your population is costing you 80% of your entire book of business from a medical cost perspective. Let's focus on that 20% and really identify who they are, make sure they're being seen, make sure they have a care plan put in place, and make sure that they're adhering to that care plan. And you do that through a multitude of mechanisms, including home care and follow-up visits. But really what we're trying to avoid is readmissions to hospitals, because that at the end of the day is going to drive significant cost. Our operational pillars for P3's playbook, we talked a lot about these, or a little bit about these in various kind of capacities, but we have patient outcomes, right? We're really targeting measurable outcomes that are above and beyond what they would see in a traditional fee-for-service environment. And again, that is highlighting some of those riskier populations, making sure that they're going to the right subspecialty and or that they've got the right care program in place. And ultimately, we're trying to drive that at a 4-star across our plans as well. We're enabling these physician groups with some technology, like some point of care tooling that sits as an overlay to their EHR that allows them to see all of the interactions that member may have had outside of their own physician group. So they may have gone to a hospital, they may have gone to a specialist. We import that data and push it back out to the physicians so they can see all of that's happening, and allows them to get a better perspective of where that member ultimately sits and what care is happening, so they can partner with us and have the right treatment plan moving forward. And then scale. Ultimately, at the end of the day, what we've talked about here is our back office model and the front of the house touch points with this allow us to scale relatively easily as we think about this moving forward. And we don't have to have a large capital outlay in order to take on significant more lives in any one of our markets. We have a glide path that we kind of think about as we partner with a physician group as we go from fee-for-service to value-based care. Really, it's that foundational, building the foundation with them, letting them understand who we are, what our tools are, what our capabilities are. Quite honestly, getting those physician groups educated on value-based care, what it means, and what they have to do to be successful in that arrangement. And then understanding how they go about referral management and things of that nature, which effectively is managing care, right? Managing cost of care. And making sure that we're sending our members to specialist groups that are not only at a lower price point because of network contracts, but also driving better output and quality scores than they might be if they were going to go and make a referral on their own. And really, we're trying to empower that network in stage 2, optimize the performance in stage 3, and then building that glide path as we think about that full risk transition in stage 4. And this can be anywhere from, I'd say years 2 to years 3. You don't want to just jump into a risk arrangement with a new group that hasn't done value-based care before. I'm not going to spend a bunch of time on this because I want to be sensitive of the overall time. But effectively, when a member comes into P3, they're coming into a holistic care coordination environment that operates with the PCP, identifies specialists that they need to see, that we're dealing with the payer, and we're dealing with the contracts that the PCPs don't have to do that. So ultimately, at the end of the day, we're trying to act as that liaison that's driving the coordination of care across all of those partners to hit our quadruple aim that we discussed earlier. This was a case study that we put together internally that shows Part C medical costs in one of our markets where we have a pretty heavy directed network, and where we were driving approximately a 15%, just a little less than that, a lower Part C medical costs than a payer in that same market. We actually showed them this data, and they were really surprised to see this, and we actually went and they have come and switched over to some of our contracts, or we're in the process of doing that today. But effectively, this was saving an $18 million medical cost reduction across our book of business. And if it wasn't there, we would have had $18 million higher cost. And you can kind of see the bottom left, we saw 34% lower cardiology spend, outpatient surgery was 40% lower, and then home health was 69% lower. And this is where we talk about P3 from a standpoint of its turnaround. The company has not been profitable since it went public in 2021. With the new leadership put in place at the end of 24 and early 25, we announced a path to get $130 million of EBITDA growth effectively in 2025. And you can kind of see the three pillars that we bucketed that improvement across, which was operational efficiencies, contract rationalization, and revenue, and I would say operational optimization. And when you look at year over year, 2024 to 2025, we'll generate about $100 million of that EBITDA growth opportunity.
5 minutes remaining.
Thank you. Of that opportunity, which is pretty meaningful in our business as we think about this. And we're thinking about this 2-year turnaround as being a $200 million turnaround. And this is where we get into 2026. These are our opportunities in industry tailwinds. Really, we believe that there is roughly 120 to 170 of EBITDA levers that we can pull to try to drive increased value in the business. Will we execute all those? There'll be a bunch of puts and takes that go into when we ultimately issue guidance in Q1 of 2026. But this is how we're thinking about 2026. And we think this demonstrates the continued value proposition that we're bringing to P3 to get this to a profitable run rate moving forward. And we believe 2026 will be a year that we hit positive EBITDA as an output of the exercises we've gone and undertook over the course of the last 18 to 24 months.
What's your revenue rate right now?
This year we are at like 1.45 billion.
Really, in revenue?
Yeah, in revenue. Yeah. And so, that revenue is actually a little less than it was in 2024 because we have less members.
You don't have positive EBITDA on that?
We do not have positive EBITDA on that number right now.
How do you sustain yourself?
Right now, we are, from a capital perspective, we are continuing to evaluate our capital needs moving forward. We've taken on some additional debt in 2025 to help fund core operations.
How much debt do you have?
We have about $240 million of debt on the books. So, yeah. And our expectation is that when we issue Q4 results, as well as then do guidance for 2026, if we hit our expectations on operational execution and demonstrate that in Q1 and Q2 of next year, we will be in a position to renegotiate some of that debt to
What's
a more.
your average interest rate right now?
Oh, that's a great question. I will tell you that it's probably in the neighborhood of like 15%,
Really?
16%. Yeah. I mean, I think that goes to show, just from a perspective, we haven't been profitable yet. So
you have like banks that are like
so right now our largest shareholder is the private equity that took us public, and they continue to be a strong supporter in our business and the model and the execution of the turnaround, and have provided some additional capital in some of those debt financings that we did in 2025. Last thing, and I know I'm on time here, this demonstrates what I was just kind of trying to articulate. We reported $167 million of loss in 2024 on a normalized basis. That is pushing the cost into the right periods. It was about 191. And then we're going to show roughly in that neighborhood of $95 to $110 million loss, which is that $100 million improvement. And then just trying to articulate the 120 to 170 that's moving forward as we see the opportunity in 26. And we are now having conversations about what's that growth model look like for 27, 20, and 28.
With more than 6,000 small and micro-cap companies listed, if you're looking for the next Apple, then Channel Check truly is your trade. It's an investor community where you can access independent Wall Street research, advanced market data, balanced news, corporate videos, and podcasts. You can even register to attend in-person Meet the Management Series luncheons, and to be part of the preeminent annual Small and Microcap Investor Conference, NobleCon. And here's the best news. Since Channel Check is sponsored by the featured companies, premium membership requires no investment. It's absolutely free. So check it out. Log in today. Find out why Channel Check is North America's leading source of research on the companies that just may change the world.